Dear colleagues, my name is Alessandra Gennari and I am a medical oncologist from Italy, and I will now give this presentation on metastatic breast cancer review with highlights from the major conferences of 2025. So one of the most important fields this year was the changing paradigm in metastatic luminal breast cancer, especially for concerning the definition of primary or secondary endocrine therapy resistance. So the first data that we will have soon, actually in the clinical practice, is the data coming from INAVO 120 phase 3 trial, comparing in patients with endocrine resistant disease after adjuvant therapy and bearing PI3K mutation. This trial randomized patients to receive the combination of inavolisib plus palbo plus fulvestrant versus palbo plus fulvestrant, and there was a clear benefit in terms of progression-free survival and also overall survival for this very unfavorable patient population, favoring the addition of inavolisib to palbociclib and fulvestrant. If we go to maybe an even hottest field, what to do after progression with the CDK4/6 inhibitors. So after first line, including CDK4/6 inhibitors, here I took these very comprehensive slides from Antonio Marra. And as you can see here, we have a number of trials in this patient population, and some of these trials were presented this year. We start with the EMBER-3 trial that led to FDA and EMA approval of imlunestrant single agent in patients with advanced breast cancer, pretreated with adjuvant endocrine therapy or progressed on first-line adjuvant endocrine therapy plus CDK4/6 inhibitors. Patients were randomized to receive imlunestrant single agents versus standard of care versus the combination of imlunestrant plus abemaciclib. The comparison that was taken into account in this analysis was between imlunestrant plus the combination of imlunestrant plus abema in patients bearing ESR1 mutation, and as you can see here, there was a consistent benefit for the combination of imlunestrant plus abema versus single agent imlunestrant in patients who were previously pretreated with a CDK4/6 inhibitor, with a 6 months improvement in median progression-free survival. The SERENA-6 trial was an intriguing trial that was presented in ASCO this year. In this trial, patients who were pretreated with CDK4/6 inhibitors plus an aromatase inhibitor as initial endocrine therapy for at least six months, and where in those patients where there was a detected ESR1 mutation by circulating DNA with no evidence of disease progression from a radiological point of view, these patients were randomized to receive camizestrant plus the CDK4/6 inhibitor plus placebo for aromatase inhibitor versus continuing on the same treatment. So continuing an aromatase inhibitor plus CDK4/6 inhibitor plus, in this case, placebo. Primary endpoint was progression-free survival. This intriguing trial clearly showed that there was a clear early separation of the curves, favoring those patients who shifted to camizestrant before progression at the onset of ESR1 mutation. This trial maybe has no direct impact on the clinical practice today, but it clearly showed that there might be a benefit in anticipating the progression on radiological scan. The Vera trial is another very interesting trial that was presented at past ESMO main meeting. In this trial, patients who were pretreated with no more than 2 lines of endocrine therapy in metastatic breast cancer, but one of these line of therapy had to include CDK4/6 inhibitors, so we are in the post-CDK4/6 inhibitor environment. These patients were randomized to the combination of giredestrant, a SERD, plus everolimus versus standard of care, which is single-agent endocrine therapy plus everolimus. The primary endpoint was progression-free survival. This trial clearly showed that there was a significant benefit in those patients bearing an ESR1 mutation with a median progression-free survival from 5.45 to almost 10 months. But the benefit was observed, and it was statistically significant also in all comers. So this is another important data. Victoria is another trial in the same patient population where patients with the PI3K wild-type metastatic breast cancer progressed after or during CDK4/6 inhibitors plus an aromatase inhibitor were randomized to receive gedatolisib, a pan-PI3K inhibitor, plus palbo, plus fulvestrant versus the combination of 2 drugs, gedatolisib plus fulvestrant versus fulvestrant single agent. In this part of this trial that was presented in ESMO, only patients with PI3K wild-type disease were included, and actually there was a significant benefit favoring the doublet versus fulvestrant and also the triplets versus fulvestrant. There was also a trend in this trial for an improved survival, but it was not clear yet. The only comment that we can do for this trial is that, of course, combination of endocrine treatments works better than single agent endocrine treatments. However, we must also take into account that gedatolisib has a particular schedule, is an IV weekly drug. So this might, in some case, represent a barrier to its implementation. Remaining in the luminal subset, we have also patients who are not anymore candidate for endocrine targeted therapy, and in this case we have the arrival of the immunoconjugate. We have data with deruxtecan, sacituzumab, and datopotamab deruxtecan. In the ASCENT-07 trial, patients that were not pretreated for prior chemotherapy for luminal HER2-negative breast cancer, that were progressed on more than 2 prior lines of endocrine therapy plus also CDK4/6 inhibitors, including those patients with early relapse less than 6 months after the start of CDK4/6 inhibitors, were randomized to receive sacituzumab or treatment of physician choice, including chemotherapy, of course. In this trial, this trial failed actually to show a significant improvement in progression-free survival, and the primary endpoint was actually not met. In HER2-positive metastatic breast cancer, we have several presentations. The most important is possibly the data from the DESTINY-Breast09 trial, where the combination of deruxtecan and pertuzumab was compared with the classical Cleopatra trial in the first-line treatment of HER2-positive metastatic breast cancer. There was a significant improvement in median progression-free survival, with the median progression-free survival of 40 months, favoring the deruxtecan use. Dare to Climb is another trial that was presented in San Antonio this year. In these patients, this was a maintenance trial in those patients who were in stable disease after 4 to 8 cycles of the Cleopatra trial. They were randomized to receive the same Cleopatra schedule or to add tucatinib to the combination of trastuzumab and pertuzumab. This trial clearly showed that there was a benefit for the addition of tucatinib to the maintenance Cleopatra schedule that consists of the combination of trastuzumab and pertuzumab. In triple-negative breast cancer, we had also very interesting data concerning the use of immunoconjugates, mainly sacituzumab. In this ASCEN-04 trial, the combination of sacituzumab plus pembrolizumab was compared in first-line treatment of triple-negative metastatic breast cancer with PD-L1 positive disease was compared to the combination of chemotherapy plus pembrolizumab following the schedule of Keynote 533. To note, these patients were patients in the chemo arm were offered to cross over to sacituzumab in second line. In this trial showed a significant benefit for the use of sacituzumab plus pembrolizumab in the first-line treatment of PD-L1 positive triple-negative metastatic breast cancer, but it failed to show a benefit in overall survival due to the shorter follow-up, but maybe also due to the fact that these patients were allowed to cross over to the active drug. In the ASCEN-03 trial, sacituzumab was compared with first-line chemotherapy in triple-negative breast cancer, not candidate to chemotherapy, not candidate to immunotherapy, and actually the combination was chemotherapy or sacituzumab govitecan. Again, patients were offered crossover in this trial, and in terms of progression-free survival, there was a significant benefit in this patient population for the first-line use of sacituzumab. Again, there was no difference in terms of overall survival. The TROPION-Breast02 trial was also presented in ESMO this year. In this trial, another anti-TROP2 immunoconjugate, datopotamab deruxtecan, was compared to chemotherapy, first-line chemotherapy at investigator choice in patients who were not eligible for immunotherapy. And this was again a first-line trial that showed a significant improvement in terms of progression-free survival, favoring datopotamab deruxtecan as compared to conventional chemotherapy, and there was also a significant improvement in this patient population favoring datopotamab deruxtecan in terms of overall survival. These two last trials that were similar in the same patient population are different actually, because both sacituzumab and datopotamab in PD-L1 negative metastatic triple-negative breast cancer showed a clear benefit in terms of progression-free survival, but overall survival benefit was evident only in the datopotamab deruxtecan, maybe also due to the fact that in this trial there was no crossover to another active immunoconjugate at progression on datopotamab deruxtecan, whereas in the sacituzumab trial virtually all patients, more than 80% of the patients actually progressing had the chance to receive sacituzumab govitecan in second line. Of note, some new but very moderate toxicity types emerged with the use of datopotamab. In particular, there was an ocular toxicity that in any case was very mild. And my presentation is finished here, and I thank you for your attention.
Thank you, Alessandra. That was great summary. I think it was exciting data we saw last year in metastatic breast cancer. Can I ask you a couple of questions? When you look at the triple negative situation, do you think that we are going to use ADCs now in the first line setting for all patients?
Well, this is a different question because, you know, we have also the demonstration that sacituzumab govitecan was a disrupting treatment in the management of metastatic breast cancer patients with triple negative disease after first line. So the evidence of a survival benefit was in second and subsequent lines. So I think that this should be sized on the individual patients, because once you have a patient with metastatic triple negative disease, you must take into account all the possible sequential treatments that you may be able to use in this patient population. Another important issue is to define whether antibody after antibody is an active strategy in terms of sequencing this type of drugs, because we know that with the second antibody, the improvement in the outcome of these patients is in any case moderate. So this is another thing to be taken into account once we start the treatment of these patients in the first line therapy, especially if the patient is PD-L1 negative.
Yeah, I agree. I think there's always an individual component there as well. In the HER2 positive space, a very similar question. I mean, we've seen the DB09 data, which is strikingly better in the first line setting, TDXD plus P, than the Cleopatra regimen. And you showed in the other studies, you showed that we now have very good maintenance strategy. You showed the HER2 CLIMB-05. We also have the Patina strategy. So what do you think? Should we move TDXD into the first line setting, or shall we still give the Cleopatra regimen because we have a better maintenance understanding there?
Well, I think that here the issue is different and is easier, because actually we can divide the first line HER2 positive patient population in those patients with endocrine receptor positive disease and those patients with endocrine receptor negative disease, so the pure HER2 patient population. If the patient is expressing estrogen receptors, we have data also from the Patina trial showing that there is a significant benefit in those patients with the addition of a CDK4/6 inhibitors as maintenance therapy plus endocrine therapy plus the maintenance anti-HER2 agents, so the combination of trastuzumab and pertuzumab. And this, I think, is maybe the right choice in this patient population. Once you have the HER2 positive pure patient population, in this patient population, of course, you have the evidence of deruxtecan in the first line treatment of this patient population, yielding a very significant improvement in the outcome of these patients. However, you have also data coming from the tucatinib trial, but the maintenance regimen with tucatinib was not tested after the deruxtecan, so it was tested after the Cleopatra schedule. So we must figure out how to define if the patient needs the addition of tucatinib as, let's say, second line or not, or if we can move to deruxtecan until disease progression. There are also other trials, as you know, the METER trial that closed, and the accrual right now trying to assess whether we really need to use deruxtecan until disease progression, or we can stop after a number of fixed cycles and then maintain these patients in response with a combination of pertuzumab and trastuzumab. So I think the picture is not yet clear in the HER2, let's say, pure patient population, whereas in the estrogen receptor and the triple positive patient population, I think that we have a clear indication from the PATINA trial.
Thank you. Maybe one last question. I think the most variety, more choices we have now in the hormone receptor positive, HER2 negative space, it's very difficult to sort of decide for the individual patients. We need all the biomarkers. You showed the INAVO 120 trial. I was always very skeptical, you know, triplet. I thought maybe we can sequence at less toxicity, but with the overall survival data, I'm now very much in favor of the population to be treated according to the trial. What do you think after patient progresses after the INAVO 120 regimen? Do you think we go right to chemo, or do you think another endocrine-based strategy is useful?
Well, thank you. We must take into account that this is a very unfavorable patient population in any case, even with inavolisib addition to the regimens that we use in this patient population. Of course, once they progress, we have to take into account other drugs, such as chemotherapy. I'm not sure that pursuing the estrogen receptor-related pathway is a winning strategy. We should take into account other type of drugs, including chemotherapy, but also immunoconjugates if the patient is HER2 low, or other type of agent in this patient population.
Thank you. I think, again, great summary. Congratulations. I think you wrapped up the year very concisely. Thank you so much.